Okay, good morning. So today I will be continuing with the topic of the orofacial pain. So in today's topic, so we will be dealing with the pain related, the pain which are related to the psychological factors and other than the neurogenic factors. So as we know that the pain can be of the originated in many types, could be of musculoskeletal, could be of neuropathic, neurovascular, vascular, or again psychological associated. So today we shall start with atypical facial pain. So as you know, the word itself suggests atypical facial pain. So it means that the facial pain which is not normal or not unique to the as usual could be of means it does not have any particular cause for it. So it basically refers to a group of a mixed group of conditions which are defined and diagnosed by inclusion of other typical patterns of facial pain. So that's why it is called as, and also it is called as a typical facial neuralgia or the idiopathic facial neuralgia. So basically here we are excluding the other etiologies, and when there are no particular etiology found in related to that pain, so then we can term it as atypical facial pain. So sometimes it's also called as the atypical odontologia, but it is a controversial and very debatable terminologies which have been interchanged. So what some of them they have termed atypical odontologia or atypical tooth pain, what we can say it as. So that is used in context when the pain is confined to only to the teeth and gingiva. So that's where they call it as atypical odontologia. But when in the term atypical facial pain is used, so when it is used in the other parts of the face. So that's how these two terminologies can be faced. So let's stick with our atypical facial pain. So as it says, it's usually psychogenic and occurs in patients who suffer from depressive reactions, or the patients who are very anxious, or patients who are which are related to the mood disorders. So that type of patients have been seen in this category of pain. So coming to the clinical features, am I audible?
Yes, sir.
Yes, sir.
Okay, so in the clinical features, so age and gender distribution, so it is most commonly seen in the later part of the life, so only in the older age of 60 years or 6th decade, and females or the women are the most commonly affected with these disorders. So how do they explain about this pain, the characteristics of pain? So this condition is characterized by pain that is deep, poorly localized, and vaguely described by the patient. So patients will not give you the exact. So the patient will say, I have pain in all over my face, all over my head. So the patient is not particular or does not know where exactly the pain is originating. So that's why the patient gives the vaguely. It does not mean the patient is making up the thing, but this type of disorder is such that the patient will not able to locate the origin of the pain. So that's why, and probably when on an examination, you will not be finding any particular cause to it, or like could be of any injury, trauma, nothing of sort of history, but just patient gives a history of pain. So the patient, the pain is often the pressing, pulling, or burning, or aching type of pain, and the distribution of pain is not anatomical. So anatomical in the sense, usually if you remember in your previous lecture, you must have dealt with trigeminal neuralgia or other cranial nerve neuralgia. So they have particular areas. So if you diagnose, I mean, if you talk about trigeminal neuralgia, so you have your ophthalmic branch, you have your maxillary branch, you have your mandibular branch. So any particular area or the particular region, so they're going to distribution. But whereas in atypical pain, it does not have any such thing. So it is very randomly distributed all over your the face. And usually it is referred, the pain is usually referred to your temple, your neck region, occipital, or even the back of your head. that's how the patient is going to explain about the pain. So clinical diagnosis is a very tricky thing when it comes to atypical facial pain, because here you have to rule out all the other possible things. Then only you can. So for that matter, if you go down here, I have written the disease to be ruled out for diagnosis for atypical facial pain, starting from sinus allergy, cracked tooth syndrome, headache with referred pain, or the pain which is impinging on the nerve, myofascial pain, or temporomandibular disorders. So all these things has to be ruled out. And when you find nothing is related to that, so then only you can justify that, yes, this is a possibility of an atypical facial pain. So that's why the diagnosis is usually done on the basis of exclusion criteria of the other thing. So apart from this, so pain does not have any anatomical distribution as we previously described, and the symptoms indicate some emotional illness and when significant organic development is lacking. So these are the factors that we have to consider whenever you want to diagnosing of a atypical facial pain. So how are we going to manage the patient pain? So this is the overall management. Lot of counseling and motivation to the patient has to be done regarding who are the patient diagnosed with this. So first of all, the patient has to be reassured and given assurance and this thing that because most of the patients who are suffering from this are very anxious about this. So you have to assure them that it is not a life-threatening disease. So because most of the patients come to you because they don't know what's happening to them, because they are getting a very vague pain all over their face and they're very much apprehended or anxious. So that has to be properly educated and motivated for the patients. So among the drugs, most commonly are tricyclic antidepressants, mainly amitriptyline, nortriptyline, which are given in the low to moderate doses and found to be effective in this patient. So, and other therapies like psychotherapy means if you detect this, even you can consult, or the patient can be referred to the psychologist for counseling, behavioral modifications, and even transcutaneous electrical nerve stimulation, that is the TENS therapy. So they also be found some sort of symptomatic relief in some patients, or sympathetic nerve blocks are also helpful in this atypical facial pain. So these are some of the management protocol that we can follow it. Though this is a very, the cases cannot be dealt so effectively because the patient may not be convinced, because the patient is under psychological stress, so cannot actually react or respond to your treatment properly. So for this type of patients, so it takes a longer time for them to relieve of this pain. Okay. So next disorder similar to your atypical facial pain is your burning mouth syndrome. So this is again one of the psychogenic pain, so that usually the patient complains about it. So basically the burning sensation accompany many inflammatory or ulcerative disease of the whole mucosa. But the term burning sensation is reserved for describing the oral burning that is not that has no relatable causes. That means the patients coming to you will be complaining, I have burning sensation or unusual sensations that is present in my whole of the oral cavity but the patients will not be giving you the exact cause for how it started. So they are just be telling you they have just got a burning sensation in the oral cavity. And apart from this, there are no, if on examination or on history, there are no mucosal lesions or no neurological or systemic disorders present, and there are no characteristic laboratory abnormalities. So if you go for any further investigation, so you will not find any of this etiologically, not clinically, as well as laboratorically. So that's how this burning mouth syndrome has been presented. So the IASP, so IASP is the International Association for Study of Pain. So that is the board or the academy, you can say, who mainly deals or give further research in terms of the pain-related disorders. So they defined BMS, that is your burning mouth syndrome, as a burning pain in the oral mucosa. And some of the other terminology that the people have also used related to this as glossodynia. So glossodynia basically is the burning pain or the burning sensation in the tongue only. So whereas your burning mouth syndrome, it is involved whole of the mucosa. So that's how these two are different. So coming to the etiological factors, so that they have been mainly classified into your local causes, systemic factors, and your psychological causes. So local causes, what they we may suspect in burning mouth syndrome, it's mainly of any of the candidiasis infections. So that is the one possibility. The patient, because it is usually seen in the older patients, and the possibility of because of their lesser immune response, so this candida infection may have been a cause. Denture wearer, yes, there is one, the patient usually with denture wearers is complaining about that. Decreased salivary output, xerostomia, that's another important cause, and parafunctional oral habits. So any of this, your bruxism, clenching, biting or tipping of the teeth. So this also could be the causes for burning sensation. So systemic related causes, we can suspect of nutritional deficiency disorders, especially iron deficiency, anemia, vitamin deficiency. Yes, they also play a role in this mucosal, excuse me. As we know that vitamins are very important for the development and the rejuvenation of your mucosa. So any of these deficiency may also lead to this symptoms of burning your pain. Hormonal changes like menopause, diabetes, thyroid and parathyroid disorders, or any other the drugs which the patient is on can also be a possible cause for this burning mouth syndrome. So apart from this local and systemic, even the psychological aspect also can be is put into that. So the patients with burning mouth syndrome are described to have a higher level of anxiety. Yes, so this you can assess whenever you are taking the history with the patients. You can make out like from their face or the way they talk to you or they respond to you. So you can make out like the patient is very anxious, highly anxious about what the complaint the patient has come up with. Depression, yes, the patient, if you assess the depression disorder, the patient may be suffering from that. Cancerophobia and mood disorders, yes. So usually the patient, before visiting to a dentist or a oral physician, the patient must have been visited to other specialists or other doctors who are not been able to tell them probably or put them into a misconception, a wrong disorder that you are suffering from a very chronic disease or something like that. So the patients will be more anxious and apprehended, so thinking that so the patient is really suffering from that. So even that can even aggravate these disorders. So these are the factors so that may lead to this symptom of burning sensation in the oral mucosa. So as such, exact etiology has not been known. So these are the possible suspected factors in most of the people they want to present with this symptom. Clinical features, yes, age and gender distribution. So it is usually occurs in 5.1% of general populations. And most of the populations is in the 5th decade, 6th decade, like about 50 years of age. Females are affected more commonly than males. So the site, what the patient usually complains is the tongue. So tongue is the most frequently affected, followed by denture veining areas, your buccal mucosa, throat, and the floor of the mouth. So these are the areas where you can suspect or where the patient complains about the pain in this area. So the burning can be intermittent. So how the patient can get the nature of this burn sensation. So burn sensation is intermittent and constant, but eating and drinking or placing candy or chewing in the mouth can relieve the pain. So the patient usually says generally when the patients are at rest or not doing any such work, so the burn sensation is continuous, intermittent, or constant. But when the patient is having chewing or drinking or having food, so these symptoms are not seen or it is relieved. Patients are often apprehensive and admitted to being very generally anxious. So as I told, so this disorders are related to the psychological affect. So the patients seems to be in an anxious mood. And they also have symptoms that suggest depression, such as decreased appetite, insomnia, loss of interest in the daily activities. So these are some of the other history or other behavior you may observe in these patients who are complaining of this pain. So it is always whenever you suspect this type of pain, so it is always very important to assess the psychological evaluation of such patients so that you may come to this probable diagnosis. So apart from this patient, yes, as I told, they are apprehensive and they are very anxious. So they may also have symptoms suggestive of depression, like decreased appetite or loss of interest. Okay, the same, I think. So what are the aggravating relieving factors? So aggravating relieving factors means the factors which can instigate or more aggravate this nature. So like fatigue, include tension or hot food sometimes. So usually on sleeping and eating or distraction, means if the patient has been distracted or patient is motivated to not to think about this more and to distract to other work or any other activities, so this pain will be reduced. So these are the features, clinical features, how the patient is going to present with that. So once you have the features and you have diagnosed, so diagnosis basically on the probable, as I said, there is no particular etiology or no origin of it, as well means there is no odontogenic origin or the non-odontogenic cases. So it is just a mere on the history that you're going to make up and some of the clinical features, you're going to make up this diagnosis. So once you have done that, so again, the management. So management, as in the etiology, I have mentioned about some of the local causes or the systemic causes. So the removal of the cause or correcting of that disorders. For example, if the patient complains about older patients who is complaining about a denture or having any allergy, or if the patient is having the habit, parafunctional habits, so that has to be corrected and educated regarding that. So by telling that these are the possible cause for the this disorder to occur. So apart from your education and motivation and encouraging for the patients, so the main the motive or of a oral physicians or for the dentist to make is to relieve the patient of its symptom. That is a symptomatic treatment. So that is what we have here is your burn sensation or the pain. So that has to be relieved. So for that, you can start topical therapies of anesthetic products like lidocaine, which is present in the form of a gel, and benzidamine hydrochloride. So they come in the form of a mouth rinses. So these two are very effective in relieving, symptomatically relieving it. Okay, so they are not means completely, but yes, the patient with a severe pain and burn sensation, so these things can be relieved very easily. Multivitamins, yes, so this has to be administered for this. Then systemic drugs like again antidepressants, antidepressants like amitriptyline, clonazepam, alpha lipoic acids are also advised. So these drugs are found to be effective in treating in these patients, because as we know, these patients have got a psychological background or psychological disorders. So it may take a longer time for these patients to be corrected or to be relieved of the pain. Again, one more therapy which are usually seen in are developed in the older patients is the cognitive behavioral therapy. That is to replace the patterns of negative emotions and thoughts with more realistic and positive ones. Yes. So this has to be done very effectively. It means we have to give more time for the patients. So moreover, who are the patients with the disorder, they come out, they are in a very higher depressive disorders. So they need someone to talk or to let out their emotions out. So you have to be very patient enough to listen to them and even correct them, whatever they are doing, or motivate them or encourage them in a positive way. So even this therapy of counseling, psychological counseling has helped in relieving the symptoms of this disorders. So this is how you're going to manage the running mouth syndrome. So apart from this, you have the vascular pain. So again, vascular pain, there are many of this in disorders. So the vascular pain usually from the vascular structures. So your any blood arteries or the nerve which is impinging closer to the arteries. So that may be categorized in this type of disorders. So in that, the first disorder which we are discussing is of the migraine. So as you know, again, the migraine is the headache. Usually, I think some of you must have experienced or some other around them. So you may be knowing the symptoms. So it is again a headache, most commonly caused for is the vascular headache, which may occasionally causes the pain in the faces and jaws. Yes, again, the migratory type is there in this disorder. The classic theory, and again to the causes of the migraine, is caused by the vasoconstriction of intracranial vessels, which causes the neurological symptoms, followed by vasodilatation, which results in the pounding headache. Yes, so you can just make out. So it is only when your vessels get constricted, intracranial vessels get constricted. So it could be of many causes. Could be of your nerval disorder or your the muscle dysfunction, or even your artery or the vascular disorder, so that may cause into it. So apart from this intracranial vessels or the arteries constrictions, so even other factors have also been known to trigger it. They not be the causes, but it may trigger in some patients, like foods like nuts, chocolate, red wine, stress, sleep deprivation, or hunger. So these are some of the factors which can aggravate this migraine. So there are several types of migraine. Usually you have classic, common, basilar, or the facial migraine, which is also called as keratodynia. So let's see the clinical features of the the normal behavior of this the migraine. So it can usually begins at young age, primarily affects the women in the ratio of 4:1. The location in the head, it is as similar as to of your common headache, but here it will be unilateral. So means it can go to affect one side of your part, could be either right or left. And also it may be referred to your temporal, frontal, and orbital region. And rarely it can be felt in the parietal, post-auricular, and the occipital areas. So usually these headaches often begin immediately or soon after the awakening. So that's how it's going to start. And the attacks may be recurrent or episodic, which variably frequent, usually 1 to 4 times in a month or in just a period of time. So this is the onset or the sequencing of this headache of the migraine is going to take place. So again, it starts with a mild headache, which later increases in severity. It is of throbbing quality at the peak. So usually it does not give you a severe one, but starting mildly, and it can, in some patients, it can go into a very severe type or a deep, intense pain. So apart from the pain, the patient may also complain of nausea, vomiting, anorexia, sensitivity to light and sound, and mood changes. So these are the other symptoms the patient suffering from migraine present to you. Treatment or the management, yes. So severe attacks or the severe causes or the severe cases, so they can be controlled by ergotamine tartrate combined with caffeine, aspirin, acetaminophen, belladonna, and phenobarbital. So these are some of the drugs so that has been used effectively in management. In the mild cases, it can be treated by methadone, beta-adrenergic agents, and the calcium supplements can be effective in this treating this. So in the non-pharmacological effect management, along with your pharmacological, so you have your proper diet control, means you have to find out if there is any allergic or any triggering factors in the food that is causing that. So that has to be known and eliminated from your diet. Stress management, sleep regulation, and the pressure on the ipsilateral carotid artery if it is detected in that artery. So these are some of the non-pharmacological managements that you're going to do or deal with the migraine. The other type of vascular pain that has been seen is your cluster headache. Yes. So cluster, you can more means it's a combination or a group of area or the areas within that, so that is causing the pain at a time. So this is characterized by episodes of severe unilateral head pain occurring chiefly around the eyes and accompanied by the number of autonomic signs. So basically here it is also unilateral as migraine, but it is occurring in your around the eye in the periorbital area. So that is the region where your cluster headache is going to occur, where the patient is going to come with you. The term cluster is used because the individuals who are susceptible to cluster headache experience multiple headaches per day for 4 to 6 weeks, and then they may be without pain for even months or years. So that's how it happens. So it happens in a particular time or for this particular days. So that's why it is termed as your cluster headaches. And later on, and sometimes, and after that, it may completely vanishes and again come back after a few months or years. So that's how this cluster headaches behaves. Etiology, as we know, this is a vascular cause. So this is caused by an abnormal hypothalamic function, head trauma, and abnormal release from the mast cells. Triggering factors: headache can be initiated by alcohol, other abusive drugs, and nitroglycerin. So these are some of the factors which may be the probable cause for this cluster headache. Clinical features: more common in 3rd to 4th decade of life, and strong male predilections. Yes, so far we had seen this pain getting in more of female. So this is seen in more of in in male. Location, yes, this is one important thing. Always going to remember to differentiate from the other pain. So it's a very deep, intense pain will last 15 minutes to 3 hours, which is unilateral and involves the periorbital area. Means it's around your eyes. So the pain is mainly localized in around the eye, and it is often radiating pure ipsilateral on the same side. On the temple and the maxilla, including the teeth. Yes, sometimes the patient may also complaining of the pain in the teeth. So that's why it's very important to find out the origin of the pain whenever we are dealing with this orofacial pain. So the pain is present in the distribution of the ophthalmic neuron and a nerve, and that's why it is confined to your eye. The pain is paroxysmal, burning, lancinating without any trigger zones. No, unlike trigeminal neuralgia or facial palsies, so you don't have any triggers where particular area you touch, the patient is having. No, you don't have that. Only it is confined around your eyes. So it is also called as alarm clock headache. So this attack develops regularly, usually once a day over a prolonged period, and some patients the same time in a day for this reason is referred to as alarm clock. Means it can, if the pain is present for a few days to few weeks, so usually it happens at a particular time on that day, and why it's called alarm, because you have set it up your alarm daily for that particular time, and you're going to wake up the same time. This headache comes every day or every other term in the same time. That's why it's also known as the alarm clock headache. Other associated symptoms just lacrimation from the eye, nasal congestion, rhinorrhea, forehead, and facial sweating are also have been seen. Masses and eyelid edema may have also been seen in some of the patients. So the main features that you're going to see in cluster headache is the origin, means the area of the periorbital region, and your alarm clock headache. So occurring at the almost same time for the term as long it stays. So the patients will be knowing that it's going to occur this particular time or in this particular area where it's going to stay. Management, yes, drugs which are used in our ergotamine. You have prednisolone, lithium carbide, indomethacin, methyl seragide maleate, verapamil, samatriptan will be giving relief in some of the symptoms. Though, as we must remember, most of this psychological or the vascular origins, the pain cannot be relieved initially on this. So a lot of, as I said, motivation, education, and encouragement has to be done. So apart from these drugs, even inhalation oxygen may shorten the attacks. Surgical intervention has been tried: trigeminal sensory rhizotomy, superficial petrosal neurectomy, gamma knife radiosurgery, which are also been indicated in your trigeminal neuralgia, and decompression of the nervous intermediates. So these are some of the surgical and the non-surgical management of this cluster dex. So even in the vascular plane, even you have other thing. So you people can just go through that in your orofacial pain part. So these are some of the important or the most commonly which you may come across in the clinics. So that I have discussed here. Okay, so this finishes your orofacial pain. So any doubts or questions? I hope